Ladies and gentlemen, now I'm repeating what I said a minute back uh, about this webinar, and of course I'm repeating it simply because I had not unmuted myself at the vagaries of age. I'm sorry about that. Okay, friends, good morning and welcome to our eighth DiaBeat webinar. Eighth in this series. And we've had two or three series of diabetes challenge over the last few years. Today is the 4th of October. We come to you from Ras Al Khaimah in the UAE, and our topic is diabetes and eye care. Now, well, when you talk about the eye and you talk about the ailments or problems or medical situations relating to the eye, you hear about retinopathy, which is a leading cause of blindness. You hear about glaucoma that finally affects the optic nerve. Cataracts are very common in older age. It tends to cloud the lens of the eye. Then you have retinal detachment, blurred vision, vision loss, and so on and so forth. And a common thread amongst all these ailments that I've spoken about is diabetes. The more I read, the more I see the connection between diabetes and many of these eye ailments. And what is frightening to a diabetic is that 27 to 30% of diabetics will have eye problems and probably more. Blurred vision is a good example. I know when I get up in the morning, I don't seem to see too well. I will need to get in touch with Dr. Munaf to find out if there's any connection between that and my own diabetes, in a manner of speaking. However, that's only an introduction to our subject. And speaking on this subject today is Dr. Munaf Hamada. What is exciting for me is the fact that Dr. Munaf completed his MS, that's his postgraduate degree in medicine. He did his MS in ophthalmology in 2016 from Damascus University in Syria. In my book, Dr. Munaf is a young, bright medical professional. Now, if you look at his expertise, I see in this list cataract evaluation and surgery, LASIK, refractive surgery, glaucoma diagnosis and management, the entire spectrum of diabetes, diabetic, eye care, retinal disorder treatment, pediatric ophthalmology, laser for PCO, ocular infection management, inflammation and trauma. He manages the entire spectrum of eye-related disorders. But what stands out in his profile is the second paragraph, which says positive attitude and compassionate care for his patients. And I think that is vital. In Apollo, we refer to that as tender, loving care, which is complementary to the improvement of all ailments. Uh, it says over here that Dr. Munaf is fluent in Arabic and English, and I am sure I've mentioned this before. It's meant to be said in humor and in jest. I'm sure that Dr. Humada will be talking to us in English. Dr. Munaf, the floor is yours, sir.
Good morning, everyone.
Good morning, Dr. Munaf.
Good morning. Okay, today we will speak about diabetic and eye care.
Yeah, but we can't see your PPTs, Dr. Munaf.
Uh,
You need to share your presentation.
okay. Okay, good morning.
Good morning, Doc.
Good morning. Good morning, everyone. Today we will speak about the diabetic and eye care. Diabetes is a major concern for healthcare system throughout the world. The prevalence of diabetes is okay, relentlessly increasing, particularly in the work-aging adults.
Doc,
Approximately,
would you like to make your slides a little larger? Dr. Wilku, can you advise Dr. Munaf on how we can do that?
Yes, sir. One second.
yes. Okay.
Yes, thank you. And Doc W, have you mentioned about removing the top banner and all these things?
Okay.
Yes, sir.
Approximately one half of individuals with diabetes will develop retinopathy in time, with diabetic macular edema will be the most common cause of visual loss in the diabetic patient. Ophthalmic complication of diabetes. We will begin with common. First, the retinopathy diabetes, macular edema, the main cause of visual loss in diabetic patient, then ischemia anyway of the retinovascular, then vitreous hemorrhage. Last thing, the TRD or tractional retinal detachment at the end stage of the retinopathy. Uncommon, it can cause recurrent styes at the lids, exanthelasma, cataract. Cataract, there is connection between the diabetic patient and cataract specialized for macular cataract. It can reduce the vision any time of, okay. Then it can cause a new vascular glaucoma. There's too much connection between the diabetic and the glaucoma patient. We have also ocular nerve pulses, third nerve palsy or fourth nerve. Also, sometimes it can make problems in sixth nerve. Then we have corneal problems like low sensitive of the cornea and corneal aberration and corneal ulcer anytime. Last thing, sometimes we have optic disc atrophy. Now we'll speak about the prevalence. The reported prevalence of diabetic retinopathy about 40%. It is more common in type 1 of the diabetics more than type 2. The proliferative diabetic retinopathy, or called PDR, affects about 5 to 10% of patients. Type 1 diabetics are at the particular risk with an incidence of 90% about after 30 years of the diabetic. What's the risk factors about diabetic retinopathy and other problems of diabetic? First thing, the duration of diabetes. It is the most important risk factor. The duration. Patient with diabetic before age 30 years, after age of 30 years, about 90%. It will affect about 50% of this patient. Second thing, poor control of diabetics will make screening about HbA. Then pregnancy, sometimes associated with the rapid progression of diabetic retinopathy, I mean. We have also hypertension is very common in patients with type 2 of diabetics when the blood pressure more than 140/80. And also cardiovascular disease and stroke also affect. Nephropathy, or the disease of the kidney, and hyperlipidemia, it also affect. Also, we have smoking patient, obesity, and anemia. Tip: patients with diabetes need to undergo regular retinal screening. We'll make good test for the retina for any diabetic patient, for the macula and the peripheral segments of the retina. Also, we have another tip. Diabetic can affect any, yes? Diabetic can affect all holes of the eyes segments, like retina, iris, and whole segments of the eye. So any blurry vision, we must go to the ophthalmologist to make check. Pathogenesis. Diabetic is predominantly a microangiopathy, is which small blood vessels are particularly damaged from high glucose level. Direct hyperglycemia effects on retinal cells are also likely to play the role. Vascular endothelial growth factors, VEGF, we mean, appears to be the particular importance in the former of category. Now we have the classification about the diabetic retinopathy and complication for the eye. The classification used in early treatment diabetic retinopathy, or we called ETDRS. Third stage, background diabetic retinopathy, or PDR, is characterized by microaneurysms and dot plot, hemorrhage, and exudate. There are the generally earliest signs of diabetic retinopathy. As ophthalmologists, when we make tests for any patient and see the microaneurysms, we must make consultation for internal and endocrinologist about the diabetic. Diabetic maculopathy, presence of any retinopathy for the macula. Pre-proliferative diabetic retinopathy, or we call PPDR, manifest test of cotton wool spot, any stage of the macula, intraretinal microvascular anomalies, or we call IRMA, and hemorrhage at the retina or the vitreous. PDR stage or neovascular on any space of the retina, or we called NVE, or on the optic disc we called NVD. Last stage is advanced diabetic eye disease, or characterized by TRD. When we reach to this stage, we have tractional retinal detachment. As ophthalmologists, we have a lot of signs. First one, microaneurysms is the important, as we can see as ophthalmologists, is when we are as microaneurysms at any retina, we must, when we're doing fundus test of the eye, appear frequently adjust to areas of capillary non-perfusion. That's the earliest sign of diabetic retinopathy as we speak. We can do more check for this stage by fluorescein and OCT for the retina. Now we have retinal hemorrhage. We have two types about retinal hemorrhage, dot and blot. It can be at the nerve fiber layer or deeper at the retina. Then we have the exudates. The exudates is the second important sign we can see at the retina, caused by chronic localized retinal edema. It affects the vision too much for the patient. Composed of lipoprotein and lipid, it appears like waxy yellow lesions. It can increase by size all the time to reduce the visual acuity. We can do also fluorescein to see the exudates and OCT. Now we have the most common cause of visual loss in diabetic patient, diabetic macular edema. Main reason to reduce the visual acuity is CMO, or we call sometimes CSME, consists of exudates, ischemia at the macula eye. It can be focal of the center macula, fovea at the fovula sometimes, or it can be diffuse edema. Clinically significant of macular edema, it can appear like three shapes. First one, retinal thickness of any space of the fovea, about 500 microns of the macula center. At this stage, it affects the vision too much. Or it can appear like exudate with 500 microns of the center with thickness. Third stage or third shape, retinal thickness more than 1,500 microns or larger, any part of the macula within more than one optic disc diameter of the center of the macula. Now we have cotton wool spots composed of neuronal debris at NFL. Result also of ischemia affect the visual acuity too much. Also, we have venous change like bleeding or tortuosity. Intravitreal microvascular abnormalities, or we call IRMA, between the arterial and venous because of ischemia, it appears. And the arterial change, like dilation, sometimes may be the early marker of ischemia at the retina. Proliferative retinopathy. It can appear at the retina, at the optic disc, and the iris. At the retina, neovascularization at any place of the retina that causes retinal hemorrhage. At the optic disc, or we call it MVD, any new vessels at the optic disc and sometimes make optic disc atrophy. Last thing, at the iris, or we call it NVI, new vessels at the iris may cause hyphemia at the anterior segment, at AC, and sometimes make hemorrhage to reduce the vision, at affect sometimes the cornea also. So we have glaucoma here. That means the diabetic can affect any place of age from lids, cornea, lens, iris, vitreous, optic disc, and the retina. Whole of the eye can affect by the diabetic. Tip. For any patient come to endocrinologist or internal specialist with any degree of blurry vision, he must go to the ophthalmologist to do more check about the retina. For the treatment and eye care, patient education is critical, including the need to comply with reviews and treatment schedule in order to optimize visual outcome. So the patient, he must have education about the diabetic disease and diabetic retinopathy. In type 2 of diabetic, this also involves controlling in weight reduction programs, exercise also. Diabetic control should be optimized. Too much, that's good for control the diabetic retinopathy. Other risk factors like blood pressure, hypertension should be controlled. Also, stop smoking if we can do that. Other modifiable factors like anemia and renal failure must be controlled. Tip. The key of prevention of diabetic retinopathy in patient education and long-term control of blood sugar. That's too much important to control eye effect. Now we will speak about treatment of diabetic complication of the eye. First thing, macular edema. We will speak about the treatment of diabetic complication of the eye. Argon laser. Argon laser photocoagulation was the mainstay of treatment for DMO. Laser can reduce the visual loss by 50% more than observation. Treatment as focal or grid laser. I mean, we have two types to do the treatment for the macular edema by laser, like focal or grid. Second thing, intravitreal anti-VEGF agents. We have a lot of things. We can do injection in the vitreous, like Lucentus, like Elia, a lot of things. Triamcinolone. We'll speak about that. Tip. Anti-VEGF therapy has become the main therapeutic option in treatment of diabetic, more than laser and another ways. Macular edema's intravitreal injection of ranibizumab, bevacizumab more effectively improves the visual acuity. We was doing micropulse diode laser, but now the anti-VEGF is the important thing of treatment. Also, we have intravitreal triamcinolone, sometimes in pseudophakic eyes, followed by argon laser. For BDR and vitreous hemorrhage, We have BRB, argon laser, we mean for the peripheral retina photocoagulation to prevent any proliferative diabetic retinopathy. Also, we have the pars plana vitrectomy, I mean the surgery for PPR and vitreous hemorrhage. Also, we have TIP. By check the eye retina, we can discover DM. A lot of patients in my clinic, we discover that they have diabetic by check the retina and so microaneurysms and exudate. Now I have some photos about the diabetic complication of the eye. It affects the vascular as we speak. Now we have the retina, optic disc. That's the microaneurysms. That's the exudate and cotton wool spot. That's the edema as the macula. So we can do OCT like this to check the thickness of the macula. It be more than 200 microns like this. Here we call CSME like cyst. Now we have the new vessels in the retina and IRMA, cotton wool spots as we speak. Now we will do argon laser. It's like this. Peripheral argon laser for the retina to prevent any hemorrhage of the eye. That's the last stage of the diabetic retinopathy as we speak. PDR, vitreous hemorrhage, and retinal detachment. So any patient with diabetic, he must go to the ophthalmologist to do check about the retina and hold the eye. And as we talk, sometimes we can discover the diabetic by check the retina. Thank you.
Thank you, Dr. Munaf. Thank you.
Thank you.
Thank you.
Thank you.
Uh, two or three interesting observations. One, you mentioned, and I take note of that through our webinars, that to prevent eye problems, one of the best things you can do is education. And that
Yes.
is to educate.
Education the patient about the
Yes,
diabetic.
yes, true. That's good. You also mentioned that a laser treatment could improve your vision by 50%, and
Yes.
that's very interesting.
At the early
And
stage, when we do argon laser, we can prevent the increase macular edema or vitreous hemorrhage or PDR by argon laser.
good. The last point I wanted to tell you, you showed us those lovely pictures at the end, and I can assure you that I, as an individual, I'm delighted with the fact that you saw so much of information from those pictures, none of which I could comprehend. It just shows your years of learning and your knowledge in the subject. Now, Dr. Munaf, I'm going to hand you over to Dr. Wilku, who is our resident questionnaire. He will be asking you many interesting questions to which he would like answers, and to which I'm sure many of our audience would also like answers. Wilku,
Okay.
sir, if I may hand over to you.
Okay.
Yeah. Thank you, Professor. Thank you, Professor. Thank you, Dr. Munaf, for a
Thank you. Thank you.
clear-cut, short presentation which covered everything in a comprehensive way. Most of the things were technical, but you explained it very clearly. So that
Yes. Thank you.
was
Thank you.
very good. So there are many concerns regarding eye care, whether it is diabetic patient, whether it is hypertensive patient, or in general also,
Yes.
because we see the world through eyes. So eye is very important.
Mhm.
So okay. So there was during the introduction we have mentioned, Professor has mentioned about your expertise, and in that expertise there was one yak laser surgery also. So Nazneen has asked what PCO stands for. So you can
Yeah,
explain it for
laser
the
for
cataract surgery. You
uh,
can explain that PCO laser surgery. It's very
BCO.
interesting thing actually.
No problem. When we do cataract surgery, after 1 month to 6 months, we can do something called YAG laser for the lens. When we put in the AC to make the vision more clarity, because after any cataract surgery, the lens we put have some opacities at the center of the lens. So we need to remove these opacities by YAG laser device to do the vision more clarity, not to increase the vision or to do the vision more clarity. Simple thing, yes. Simple surgery. Yes,
Dr. Wilker, you're on mute.
you are mute, doctor. I cannot hear you.
Yeah. What she's asking is what PCO stands for.
Yes, I answered you. BCO YAG laser for the lens. When we put the lens in the AC after cataract surgery, it makes
Yeah.
sometimes opacity on the lens. We need to remove the opacity by YAG laser device. Simple surgery to make the vision more clarity.
Yeah, it's
That's
a
after
basic thing to
cataract
fit
surgery from 1 to
contact
6
lenses.
months. Yes.
Yeah. The second question, Sarfraz has asked, his father is diabetic and recently he was diagnosed with glaucoma. Will
Yes.
it affect the vision?
Yes. There is too much connection between the diabetic and the glaucoma because we have sometimes new vessels at the iris. These vessels can make closed of the AC angle. So the IOP of the eye become too much high. That's the reason for glaucoma of diabetic patient. So we can do also laser for the iris or injection in the vitreous to reduce the IOP and improve the glaucoma for diabetic patient. And also we have drops and another ways to reduce the IOP of the eye.
Yeah. Thank you for that. And third question comes from Aryan. My father is diagnosed with retinal detachment and was suggested for a laser surgery. Is laser treatment safe? See, generally what happens when we
Yes,
talk
too
about
much.
laser,
Yes,
so people are very afraid of
BRB.
listening to laser.
No need to be afraid. Okay. BRB algo laser, too much safety for the eye
Yeah.
because we do the laser at
So
the
is it safe
peripheral.
for laser surgery for retinal detachment or cataract or anything?
Before the surgery for the retinal detachments, sometimes we do BRB algo laser. If you're asking about algo laser, it's too much safety because we do it as a peripheral retina. Peripheral retina. Okay, you can hear me?
Yes, we can hear
Yeah.
you, sir.
Yes.
Yeah.
The macula is the center of the vision, but the peripheral retina not affect the vision. So we are too much safety to do BRB angle laser. It not affect the vision anyway.
Okay.
Okay.
Okay. I just got one message from my patient because actually he wanted to consult me. So the question comes for eye care only. So I will put it forward to you. Now, for last 1.5 months, you might have seen many patients coming with redness eye and very much itching in the inner canthus. So we generally say most of the people are getting allergies and they're having this problem. So what they should do to prevent it or self-care?
For redness and itching, too much common here or here in UAE because the weather, humidity, AC all the time, computers, lab, you know that. That affect the eye by causing dry eye. So we can prevent it by give the patient lubricant drop, reduce using computer, laptop all the time.
Yeah, what we have to do. That's true.
What we can do also suffering from this thing. I am using lubricant drop all the time to prevent redness and itching.
Yes, yes, yes.
That's the main
And
cause of dry eye for itching and redness. Yes, that's
true, true, true. So without that, we can't survive and we have to work and we have to suffer both.
yes.
Okay.
Okay,
Okay. Doc, I would, from my personal side, what will be your three-pointer tips as a takeaway message for a general eye care? You can say the tips. 3 tips. What do you suggest?
3 tips. As I talked about that, using lubricant drop, it's too much good for the tear films, to the cornea, to prevent itching, redness, burning. That's the first step. If we can reduce using computer, laptop, mobile all the time, we can reduce because it make dryness, it make accommodation of the eye, it make the muscles of the eye too much tired all the time. If we can reduce the thing and make test at least one time a year, if we can do that, to check the optic disc retina, because a lot of problems for the eye we can check suddenly or by simple sometimes like glaucoma, like microaneurysms of the macula, and a lot of things we can discover by a simple check for the eye. So we can go to the ophthalmologist at least one time by year, if we can do that also. That's simple tips for our patient.
Okay, great. So I think I am not having more questions. Okay, thank you, Dr. Munaf. Professor, over to you.
Munaf,
Yes.
I am going to take the liberty of asking you your opinion on eye exercises. Now, if you go back to, you are from the Middle East, and therefore uh, uh, we have a large, uh, thousands of years of knowledge in the area of medicine, and so do some of us, or the community that comes from India has thousands of years of knowledge on the medical aspects. Now, there is such a thing called yogic eye exercises. And in the 1930s, I believe an English gentleman called Bates had propounded this. I'm just going to show it to you. So what we do is you put your hand over here in front and you look at your thumb and you circulate your thumb and
أيوه.
your eye is rotating.
Rotation,
Okay, then
yes.
you move it from side to side or you move it up and down. Now, we believe, I could be wrong, but we believe that by rotating the eye in different ways for a period of about 5 minutes, you may improve the circulation in the little capillaries over there. And you could, in a manner of speaking, uh, uh, benefit the muscles that manage the eye. What are your thoughts on this, doctor? I mean, I'm not talking about it as a curative aspect.
Okay.
I'm simply saying that to relax the eye, would something like this be beneficial?
Perhaps go for the eye. This exercise, we have a lot of exercise like massage sometimes. Look for far distance for the eye accommodation to relieve the eye. It's good.
Thank you. Thank you.
Thank you.
You
Thank
know, go ahead, sir.
Sometimes we have exercise for low accommodation by put our finger and do like this for some tropia, exotropia, a lot of problems for the eye if the patient has strabismus. So we have some exercises for the eye.
Good, good. You know, the difference, doctor, is that when a specialist like you uh, mentions that, yes, of course, it would perhaps be beneficial, it is not going to harm you in any way. Well, we get a lot of comfort in that knowledge.
Okay.
And with that, thank you very much, Dr. Munaf.
Thank you,
So
Prof.
much
Thank you, Prof. Thank you.
Thank you so much for your lovely lecture.
Thank you.
Dr. Wilku, as always, thank you, sir. Thank you for the many questions that you always ask. I'm always wondering where you have such an inquisitive mind from. Well, thank you very much for all those questions. To our audience, thank you so much for listening in. To my colleagues who support us with the IT technology and the Wi-Fi systems and things like that. Thank you very much. And friends, our next webinar will be on 11th of October. That is the next Friday, 11th of October. We will have Dr. Shalab Mohan, and he will be talking about diabetic foot. So I look forward to seeing you all on the 11th of October. Thank you very much and have a great day.
Thank you.
Goodbye.
Have a good day all. Thank you. Thank you.